Hi, and welcome to this third in our mini series of video interviews looking at different perspectives from the world of clinical functional MRI. In this episode, I was joined by Angela Walls. She's the Chief Technologist at the Clinical and Research Imaging Centre, which sits within the South Australian Health and Medical Research Institute in Adelaide. She has a master's degree in medical science and is also a fellow of the National Imaging Facility, which is a large network of advanced imaging centres across Australia. So thanks, Angela, for joining me all the way from Australia.
No problems, my pleasure.
So yeah, it would be great to just hear a bit about what inspired you to get into MRI really in the first place.
Sure. So, I've been a radiographer for 27 years now. So, 25 out of those, I've been doing MRI. I also did train in some other modalities, but the I think the thing that I like the most about MRI is the physics and science behind it, as well as the combination in being a healthcare worker as well.
So once you started in MRI, how long until you kind of were able to specialize in doing advanced neuro?
So yeah, the first sort of 15 years of that was probably more clinical, or general clinical MRI. But then I started working at a major public hospital where we did some lot of advanced neuro work, worked closely with the neurosurgeons and the neurologists in various aspects of their requirements. We didn't do fMRI there. In fact, the state didn't do functional MRI until we started doing it at our current centre. So our current centre is a clinical and research institute in Adelaide, Australia. And here in the last 9 years, we've grown the functional MRI imaging service for the state.
Okay, so kind of 9 years ago was your first kind of encounter with fMRI, really.
That's right, yeah.
So then, because I know at the time you were sort of not exactly working solo, but you had kind of the bulk of the responsibility. So how did that feel when you were first given this kind of additional challenge and responsibility for conducting fMRI scans?
Yeah, it was a really great opportunity to learn. Being a clinical and research centre, we all of a sudden had hardware that we had not previously worked with before. So we had the Nordic TV screen, and all the kit was there ready for us to start adopting this new service. So it was met with there was a lot of hours of work. We did really have to train, and I was very lucky to have trained closely with our Siemens scientist at the time. And but it was a lot of hours and a lot of self-teaching. It was also reaching out to a lot of centres who were already doing functional MRI imaging as well,
Okay.
seeking any information that we could at ISMRM conferences and various things. So, and also working really closely with a radiologist. So he had done some work overseas at sites that did do functional MRI, and that was really valuable in us starting up the service.
Okay. So what does the team look like now? Like who's involved at SAMRI, and what different types of roles do you have that work together towards the fMRI?
Absolutely. So our team is still quite small. So we still, for our clinical fMRI, we really are running it between MR radiographers who are trained in functional MRI. They're trained in the acquisition and post-processing, and we're just using the vendor software for our clinical, so Singovia, for instance. And we have two radiologists that we work really closely with. So they help us with discussing what the optimal paradigm might be for the particular tumor or lesion location and so on, as well as some protocol troubleshooting. So really it's still a radiographer and a radiologist model. The radiologist obviously provides a report back to the MDT team and so on, and a lot of discussion around those results. But sometimes with our pediatric cases, we do have a neuropsychologist who might either attend or may via email just guide us as to which paradigms might be the most successful for the child. And having them attend is really valuable when they can, because it provides the child and the family with a familiar face, but also it just provides us with really valuable information that we don't know. So the child's capability in their language, for instance, or their reading, or even just their concentration. So when they can attend, it's really valuable to us. We don't have much of a physicist involvement at our site. We do very much in our research areas, but clinically we sort of stick to radiographer, radiologist, and plus or minus neuropsychologist.
Hmm. And obviously, you do a combination of clinical and research there. How does that differ then for research projects?
So the research projects, we still generally run them in the same way as we would our clinical paradigms. It might just mean that we are using different software packages, for instance. So that would basically depend on what's the researcher's preference, because the researcher would build their own paradigm in many cases. Sometimes if we're using Activa, then we obviously ask Nordic NeuroLab team for help. But we still use the same Nordic television, sync box, and so on. The only difference is that we sort of feed that through instead of the serial port into the HID function. So that might just mean that we use PsychoPi, all sorts of the psychology tools that they like to use. We can use them alongside. And obviously, our research paradigms are very different. We have some very quirky and different
Mhm.
types of paradigms, and they're not always a block design like a clinical one tends to be.
So still, you're kind of you're responsible for really running those rather than the researchers coming in and taking over. Because I think
Absolutely.
that's also like a slightly um, I think a slightly unique thing about what I've seen from, sites around Australia. The radiographers have, take a lot of responsibility, and that's a really great thing. I think to see in terms of like preparing the patients and actually making decisions and looking at the data and actually having kind of a really strong grasp on all the different parts of it, really.
Yeah, we absolutely do. I think we're assessing whether our paradigm's working as we're going through. We're assessing whether we need to make it easier, make it harder according to
Okay.
patient compliance and patient capabilities. Quite often we like to get a lot of information beforehand, but sometimes we don't necessarily even know where the tumor position is if we
Okay.
have never seen their imaging, because we are getting our patient groups from varying hospitals and
Mm,
varying institutions. So we might not actually be privy to, they might say, oh, there's a tumor in the parietal lobe, but that could be, anterior, posterior. There's a lot of variation in that. So we have to make a lot of decisions on the fly. Um, and I think we still have really good success in that. It's just a complexity that we have in our site. But the
yeah.
good thing is that we've set it up so it's a bit easier to have it just run by a solo MR radiographer, for instance. We've got everything triggering the scanner triggers through the sync box triggers the paradigm. So it's taken out the timing complexities
Mm,
potentially that you might have in different setups. So, we're really thankful for that being the way that is.
yeah. When it comes to patient preparation, obviously that takes kind of that's a big consideration for every scan, kind of individually. Have you got any particular tips? Like, what's your kind of strategy when a patient walks in and you maybe don't know anything about them?
Absolutely. So we do have all of the paradigms that we've got in Activa. We do have laminated sort of examples of those. And they are from sort of, adult capability range to pediatrics. So I would try and, if I know where the tumor is and I know what paradigms, do they need motor? If so, which motor? Do they just need language? If so, we'll provide them with the four, usual set of language paradigms. Do they need memory? They're actually more hard to explain. But we'll first of all provide them with that. We also find out whether they're strongly left-handed, strongly right-handed, and anywhere in the middle. And then using those sort of cheat sheets, I'll then go and explain exactly what we're going to be doing. So preparation is hugely important. There's no point doing a fMRI examination if the participant doesn't do it. I mean, it's just of vital importance. So explaining is the key, spending as much time as they need. Also, that telling them that it's not a test, that we're not going to know if they get it right or wrong in these instances. In clinical instances, that's not important. We just want you to go through thinking of those words and, for instance, or doing that task that we're explaining. We also tell them that they don't have to remember everything for the entire test. We will come in and we will tell them exactly what we want them to do in each 4 to 5 minute block. And that normally takes a lot of the stress away as well.
Okay. Any examples of any particularly challenging cases you've had, just for those people that might be starting out or wondering what kind of complexities they might come across?
Yeah, so I mean, language, we are pretty multicultural here in Australia, and we do come up with some languages that we may not have paradigms particularly for. So if you're needing to do them in a second language, that's sometimes a little bit challenging. Sometimes people can take to them very well, and sometimes we might need to do more visual sort of object naming rather than language. Outside of language, I think gauging the the person's cognitive ability. So you do like to have a bit of a chat at the start, and this is where if we had neuropsychologists for every patient, that would take this complexity away. But we really only have that for the pediatrics. But even in adults, there's a varying range of cognitive ability, and you might need to adapt your paradigm as you're going with that. But how do you tell? You've got to be kind of quite busy having a look at what is working, what isn't working, and making some decisions around
Mm,
that on the fly as well. I
yeah.
think that's the main one. Every now and then you get someone who's highly intelligent and is just so worried about the semantics that they're a little critical about what you might be doing. So, I mean, that's entertaining, but it's a slight challenge as well. So
Okay.
everyone's
Overthinking.
different. Yeah.
Mm.
Yeah. Yeah.
So you talked about like kind of making decisions a bit on the fly as well. Does that happen very often that you're kind of scanning and then you're, depending on how the results look, you're actually kind of changing your approach or changing what you do next?
Yeah, I think particularly in the tumor cases where the tumor might be extending a little bit further into, further closer to broca area in language, for instance, or the tumor is not really allowing that patient to be performing how you and them might have thought that they would have. So you might need to change um, the the difficulty of those paradigms, I think,
Mm,
absolutely.
okay.
Particularly when it comes to language, and it's important because with the tumor, of course, then the language might have, shifted
Mm,
to the contralateral side as well. And that's an important diagnosis that you need to make. So we really need to be successful in some language paradigms to be able to, for the doctors to be able to get that information back and for that to be successful.
okay. What would you say, how would you say your approach to fMRI scanning has changed from when you very first started to now? Has it changed based on experience?
I think it's changed based on experience, as in trying to just being determined to be able to get those paradigms right for the participant. It's also based on the fact that we're getting a lot more pediatric referrals.
Okay.
So that's been our growth in the last couple of years, is the fact that we're getting so many more pediatric referrals. And we normally we could be scanning about 7 to 8 years of age. So that's the difference is in their reading ability and their concentration and so on is really variable there. So I think that just having a little bit more experience or continuing to gain that experience is really important to make those really important studies successful as well.
Okay. And then can you just kind of maybe outline a few of the research projects that you're currently involved with?
Yeah, sure. So sometimes we have studies that just might include a block motor task, so pre and post an intervention, for instance, in stroke or something quite simple, where they're essentially doing a similar thing to a clinical study, but they might be squeezing a ball with their affected the stroke hand, for instance, and they're just looking in that instance as to whether or not this intervention has changed any of their functional ability. We have some quirky ones as well. We have an event-based fMRI task that's set in a spaceship. which has really loud, ear-piercing noises and some almost jump scares. We don't want them to move, but it's meant to frighten them a little bit. So this particular study is looking at the effects of stress in control cohorts versus post-traumatic cohorts. So that's an interesting one. We also have another one where the participant is performing certain movements that they're coached to do prior, and they're performing them in the scanner, and there's actually an avatar on the screen that they're looking that's mimicking their movements, and they're looking at certain functional changes in various training methods for that, for instance. So that's another interesting one.
Yeah, so quite a variety of stuff.
Yes.
Okay, so if a radiographer came to you who's maybe working in MRI and has an interest in advanced techniques like fMRI, is there any kind of advice you might give them in terms of how to educate themselves, or how to gain experience and get involved with doing these kind of scans?
Yeah, so I mean, I think site visit is probably like it's visiting a site like ours, or a site where they do, a reasonable amount, and being able to get some exposure to that would be really important. I would always tell them that no matter how much learning and training you got, that educating your patient before they go on is the absolute key.
Okay.
No matter whether you've got, the best scanner in the world, or, a team of physicists or so on, that if your patient doesn't know what they need to do, then things will not work. And there's quite a lot of online content now. I don't know if there's courses to show you what to do, but there's certainly, plenty about the physics and paradigm design and things like that. There's really good content on the Nordic forum as well, with people asking questions that you might have thought about, or you might know the answer. And just that sort of sharing, I think, is really important as well.
Is there anything you wish someone had told you at the beginning before you kind of started scanning?
I think when you're processing a difficult case, for instance, so we process ours inline on our vendor software, so Singovia in our case. I think being a little bit better trained in being able to troubleshoot some problems that you may have. So if your timing is off, or your participant's sort of timing is slightly off, or something like that, just to be able to sort of adjust those block designs, and probably the theory behind that, I think would have helped in the early stages, rather than trying to sort of fill that gap as I went along. I think that would have been useful. But vendor software changes all the time, so you've also got to keep on top of all of that as well.
Yeah, there's a lot to think about. Okay, well, thanks so much for your time. It's been really nice chatting.
My pleasure.
And see you soon.
Thanks, Vic.
I hope you enjoyed that conversation. For more insights, please do check out the other episodes in this series. Also, head over to our website or our user forum to find out more information, and follow us on LinkedIn for future updates.